Welcome to Grand Rounds, everyone. I'd like to introduce our presenter for today, Dr. Raghu Rao, who's an associate professor in our division of neonatology and an expert in neonatal nutrition and metabolism in the developing brain. Dr. Rao completed his medical education and training in Mangalore, India, and then came to Minnesota, where he completed pediatric neonatology fellowship. Since that time, he's been a faculty member at the University of Minnesota, where his research has focused on neurodevelopment occurring under adverse fetal and neonatal conditions such as altered glucose metabolism and iron deficiency. This work has led to the use of the pioneering use of magnetic resonance spectroscopy in evaluating the brain under these conditions. Dr. Rao has served as a research mentor to many students, residents, fellows, and junior faculty, and as president of the Midwest SPR. He is currently leading our center's effort in the PEANUT study, a multi-center clinical trial evaluating erythropoietin as a neuroprotectant for premature infants. With that in mind, Dr. Rao will present his talk, Recent Advances in Neonatal Neuroprotection.
Thanks, Tate, for that wonderful introduction. It's actually a matter of pride to me because Tate did work in my lab as a pediatric resident and went on to win the award for the press for the resident category that year and recently published his paper. And now we are colleagues and research collaborators. So I have nothing to disclose. And the objectives of my talk today are to recognize neonatal populations that are at risk for neurodevelopmental impairments and review the current neuroprotective strategies that are being applied, and then also discuss some potential preventive and treatment strategies that are in the works. So why neuroprotection? So advances, technical advances and technological advances have improved the survival of neonatal population, both preterm babies as well as full-term babies. However, the incidence of common brain injury conditions have not changed much. So as a result, we are seeing babies surviving the neonatal course, but at the risk of having neurodevelopmental impairments. And this has got a huge economic and societal burden, both at the personal and family level as well as at the societal level, due to direct medical and non-medical costs, such as special education, takes about 20% of the cost, and then indirect cost, which is due to loss of productivity. So altogether, this is a huge burden. It has been estimated that the lifetime cost of caring for a child with cerebral palsy born in 2003 is approximately $1 million. So there are certain common conditions that lend themselves for neuroprotection because of the higher incidence of neurodevelopmental impairments. So in this list, the topmost probably is the extreme prematurity, defined as a birth gestational age less than 28 weeks. This is the population where the technology has really improved the survival. So even though the incidence is lower, because of the increased survival, and it's a 20 to 40% neurodevelopmental impairment, this population is probably the number one in the list that requires neuroprotection. And in late preterm and full-term infants, moderate to severe hypoxic ischemic injury, pulmonary hypertension without need for ECMO, perinatal arterial stroke, and then also we have the list here, which is a non-neurological condition, which is a cyanotic heart disease, and we do have a cardiologist with us, Dr. Moeller and Dr. Kaplan. We just talked about this particular population being at a higher risk. So these are some of the populations where we probably have to focus on improving the neurodevelopment. So looking at the prematurity, the incidence of prematurity is about 11%, ranges anywhere from 5 to 18% in the developed world. And premature birth is responsible for about a third of all neonatal deaths. And the survivors are at a higher risk for long-term neurodevelopmental impairments, including learning, cognitive and executive function impairments, motor, vision, and hearing deficits. It is estimated that at least 28% of the preterm population will have at least one complication, and about 8% will have multiple complications. And this risk is greater in the extreme prematurity, defined as less than 28-week gestation, comes to about 30,000 annual births in the United States. And this population has about 21% of major neurodevelopmental disability, defined as cerebral palsy, vision and hearing deficits, and severe motor deficits, and accounts for more than 50% of all the pediatric healthcare dollars. So the etiology of preterm brain injury is multifactorial. So there is injury to the existing tissue, and this could be in the form of hemorrhage, infection, inflammation, and hypoxia ischemia. We are not seeing the severe intraventricular hemorrhage that we used to see more frequently earlier, what we used to call as grade 3 and grade 4. But in addition to the injury to the existing tissues, there is also interruption of the normal development. The brain undergoes a 4 to 5-fold increase in the last trimester of pregnancy, both with the gray matter as well as the white matter. And there could be injury occurring during the reparative process also. And more and more we are now discovering cerebellar injury because we are looking for it. And severe cerebellar injury can also have an impact on neurodevelopment, not just on balance, but also on cognitive development. So the current thinking is what we call as the encephalopathy of prematurity, because this is a combined gray and white matter injury that is due to acquired insults, altered developmental trajectories, and also during the reparative phenomenon. As I said, it is a multifactorial in etiology, involving the hypoxia ischemia, infection, inflammation, and other insults, and is mediated through a variety of toxicants, excitotoxicity, free radicals, and the exquisite vulnerability of cells such as pre-oligodendrocytes for injury during this process. And there is injury to both the gray matter as well as the white matter, and the white matter injury could be in the form of periventricular leukomalacia, both diffuse and cystic, white matter gliosis, white matter in the neurons and axon injury, as well as the gray matter injury. So it's much more diffuse than what one would expect. So as an example here, these are the two MRI images at term equivalent age. The one on the left is the MRI from a 30-week gestation infant, so obtained about 10 weeks after birth. And the one on the right is a 23-week gestation infant, so again obtained around comparable age. And what you can see with the 23-week gestation infant is this diffuse atrophy. You can see the enlarged ventricles. You can also see the extraaxial fluid collection and a diffuse white matter as well as gray matter injury. So this is the sort of brain that we are seeing at the term equivalent age. There is going to be continuous repair beyond the term age, but this is probably what is responsible for the long-term neurodevelopmental problem. As against the preterm infants, the brain injury in the full-term neonate is usually due to a hypoxic ischemic insult, which is a much more defined acute injury. Hypoxic ischemic injury, also known as HIE, affects about 1 to 6 per 1,000 live births. Most of them are either prenatal or intranatal in origin. About 10% are postnatal in origin, for example, due to a cardiac arrest. And for some unknown reason, the incidence as well as the effects of hypoxic ischemic injury is 10 to 20 folds higher in developing countries. And both in developed and developing countries, HIE is a major cause of both mortality and morbidity, with about 10 to 60% mortality and a significant proportion, about 25 to 40% of the survivors having neurodevelopmental deficits. It's estimated that hypoxia ischemia is responsible for about a quarter of all neonatal deaths worldwide, which comes to about 1 million deaths every year. So the etiology of hypoxic ischemic injury is a two-step process. So in the initial stage, which takes place around the time of, during labor and the time of delivery, is characterized by decreased cerebral blood flow. And then during that time, there will be primary energy failure, and few neurons in the watershed zone die during that process. Following resuscitation, you have the reperfusion, and there is a latent phase lasting anywhere from 2 to 15 hours, which is characterized by partial recovery of energy and also the EEG starts to get normalized, but will be still low. And then over the next hours and days, there's a secondary energy failure, which is characterized again by loss of ATP and results in seizures, toxic edema, and then necrosis and apoptosis. It is the injury during the secondary energy failure that is responsible for the severe injury and long-term neurodevelopmental deficits. So there are 3 stages of HIE, for mild, moderate, and severe. So the mild HIE, all the infants with that condition, they survive, and the neurological deficits are seen in less than 10%. The moderate HIE, there is some mortality, and about 50% will have neurological deficit, and in the severe HIE, about 60% will die, and then all the survivors will have neurological deficits. So it's usually the moderate and the severe HIE that we need to concentrate on. So next, looking at what we have for the neuroprotection strategies currently, you can divide that as what is available for the full-term infants and what is available for the preterm infants. In the full-term infants, the biggest development that has happened in the last 10 years is therapeutic hypothermia. So even though it's something that developed in 2005, it was long ago known, so as back as in 1958, that if you left an infant with hypoxic ischemic injury alone, he or she would cool to a temperature of about 34 degrees over the first hour or so, and then maintain that low temperature for the next few hours, and then gradually rewarm. So this is a natural phenomenon where the body self-cools, and there is a feeling that what we are seeing as hypoxic ischemic injury now is we are preventing this natural cooling. So in other words, we are actually causing iatrogenic injury. So there have been then animal data suggesting that if the brain temperature is cooled by 2 to 5 degrees Celsius after HIE, there is less injury. And to get these beneficial effects, the cooling has to happen soon after the injury, within 2 to 6 hours, and should be continued for 48 to 72 hours. And there are no beneficial effects if the cooling is started later, especially after the onset of seizures, which essentially means the secondary energy failure stage, or if the temperature, if the cooling is done for a short period of time, say for example less than 24 hours. And if someone gets cooled too much, below 32 to 33 degrees, then you do have systemic effects, metabolic acidosis. So the mechanism of neuroprotection with the therapeutic hypothermia is during the latent phase, lowering the brain temperature to 32 to 34 degrees Celsius will reduce or prevent the secondary energy failure, so there is less injury and long-term deficit. So there are 2 ways the brain temperature can be reduced. One is called selective head cooling, shown here, where only the head is cooled using the cooling cap, and then you have a plexiglass covering to prevent further heat being administered from outside. Or the other way of cooling which we follow is a whole body cooling, where the infant is on a cooling blanket, and then the radiant warmer is turned off again to avoid any extraneous source of heat. In both ways of cooling, the temperature decreases quite rapidly within half an hour of starting of the cooling, and there is usually a little bit of an overshoot, and then the temperature is maintained. So this is a servo control system, so the temperature is maintained between 33 and 34 degrees for 72 hours, followed by gradual rewarming, typically taking about 6 hours, and then the baby transitions to regular care. So thus far there have been 6 major studies, randomized controlled trials, 2 of them with selective head cooling and the remaining whole body cooling, starting in 2005 and then going all the way to 2011. The last 2 studies actually had to be terminated prematurely because they were not able to recruit patients because there was loss of equipoise, so the healthcare providers were refusing to randomize the babies to the control arm based on the initial data. So what you see here is the outcome at 18 to 24 months is death or neurodevelopmental disability. So in most of the neonatal clinical trials, death and an outcome are competing outcomes. So in other words, If a baby dies, that baby is not likely to have neurodevelopmental impairment. So these are considered as competing outcomes. So the combined outcome is usually used. So in all of these 6 trials, what you see here is in the control arm, compared to the control arm, the arm that received the hypothermia had better improvement. So there was lower rates of both death and neurodevelopmental disabilities. So when combining all these data and other small studies, about 11 trials altogether, 6 of them being systemic cooling and the remaining being head and mild systemic cooling, there is a lower risk of death or neurodevelopmental disability, about a 25% reduction in the rate of death or neurodevelopmental disability at 18 to 24 months. And the number needed to treat is 7. And again, if you look at the mortality needed about 11 and neurological disabilities about 8. These numbers are extremely good. So as an example, if you want to avoid one myocardial infarction, 75 people should take statins. And if you want to avoid one stroke, 150 people have to take statins. And if you want to avoid one death, everybody should take statin because it does not reduce the mortality. So the infinity is a thing. So these are extremely good numbers. And again, the results in each of these studies shows that the outcome is better with moderate hypoxic ischemic injury relative to the severe hypoxic ischemic injury. So there are some of these studies have now published their long-term data. There have been some loss of follow-up, especially in the CoolCap trial, which was a trial done across Europe and across Europe and some centers in the United States. But all 3 studies have shown that the initial benefits seen at 18 to 24 months persist. So for example, in the NIH whole body cooling trial, the lower death 25%, 44% persisted even at 6 to 8 years, and there was no increased rate of disability. And the similar effects were seen with the CoolCap as well as the TOBY trial. The TOBY trial, which was the largest of the 3 trials, actually showed better survival with intact IQ, or at least an IQ more than 85, and lower risk of cerebral palsy and better motor function. So we can say that neonatal hypothermia does not harm, probably protects. Because one of the things one may always look at is when we use a therapy like this, are we then substituting death to neurodevelopmental disability? It does not look like, and that's what is the case. So the current practice is to offer this therapy for infants who are greater than or equal to 35 weeks and are less than 6 hours of age. And the selection and the eligibility is based on 2 criteria. The first one is a clinical and or biochemical criteria, looking at cord gases or the blood gas in the first hour of life. And a step B, which is an abnormal neurological examination. So there are 6 criteria we look at, and then the baby fulfills 3 out of those 6 criteria, then that baby becomes eligible for cooling. And both steps should be fulfilled to be eligible for cooling. And the therapy is still considered for infants less than 35 weeks or who are more than 6 hours. But the American Academy of Pediatrics recommends that such cooling should be done either in the context of a clinical trial or with the consent of the parents. The therapy is not offered for those with lethal chromosomal or structural malformations, infants in extremis, or non-HIE neurological conditions such as intraventricular hemorrhage or stroke, because we just don't have data. So overall, it's considered as an evolving therapy, but it has technically become a standard of care. There are now medical legal cases filed against the hospitals for not cooling an eligible baby. So virtually everybody cools the baby now. There are still unknowns with therapeutic hypothermia. We just don't know much about the candidate selection, particularly as it relates to the preterm infants, the optimal timing of initiation, temperature, and the duration of hypothermia, selective head versus whole body cooling. There has never been a head-to-head comparison. And then the role of adjunct therapies, such as use of analgesia, has never been tested. And we do have limited data on long-term effects, and then the effects on decision-making by parents and healthcare providers remains a point of contention, because Right now, the babies who have hypoxic ischemic injury, many of them will die because of withdrawing or withholding care. And if we are committing a 72 hours of cooling, so many of these babies probably will survive and may end up having neurological problems. So the other thing to look at is, even though the hypothermia is improving the outcome in all of these 6 cases, we do see that a fair number of babies will still end up either dying or having neurodevelopmental problems. So that has resulted in looking at other synergistic therapies. And there is a whole lot of therapies that have been considered and are at various stages of investigation, some at the animal experiment stage or the preclinical stage, and some actually in clinical phase 1, phase 2 trials, and some actually in phase 3 trials. And it ranges anywhere from interventions taken before the birth of the child and then going all the way beyond the 72 hours or so of cooling that we undertake. Some of the pharmacological candidates are considered best for these based on their properties and function, and also based on the animal data, and many of them have been tried both antenatally and postnatally. Melatonin, there are clinical trials that are going on. Xenon is a noble gas. It has got antioxidant property and anti-excitatory property, so there are trials that are using that as an adjunct for hypothermia. So also allopurinol and vitamin C and E, which are antioxidant, resveratrol, which is in the red wine, and then also N-acetylcysteine. There have also been other interesting compounds that have been looked at, for example, pomegranate seeds, turmeric, to see whether any of those will improve the outcome. So these are some of the clinical trials that are going on, hypothermia plus topiramate, hypothermia plus conidine. And this is what I was talking about, the xenon gas. So there are 2 trials that are going on. So the xenon is a very expensive gas. I think it costs about $35 a liter, and babies need about 1,800 liters. And then there is also some trial looking at the therapeutic hypothermia with erythropoietin. So what about the preterm infants? So when you look at the neuroprotective strategy for the preterm infants, you can divide that as antenatal strategies and postnatal strategies. Among the antenatal strategies, some of the measures that are used to prevent preterm delivery, such as progesterone, may also have some neuroprotective effects. But even otherwise, preventing preterm delivery can improve neurodevelopment, because, as we saw earlier, the babies who are born very early in pregnancy or very early gestation are the ones who are at higher risk. The other antenatal measures that have proven beneficial is the measures to promote fetal maturity, that is the antenatal corticosteroids, and then measures to promote neuroprotection, that is magnesium sulfate. So antenatal steroids have been used to promote lung maturity for a long period of time. But when we went back and looked at the data, it showed that the babies whose mothers received antenatal steroids had lower incidence of severe intraventricular hemorrhage. The relative risk was about 0.54. They also had lower incidence of periventricular leukomalacia and cerebral palsy. And the mechanism is probably because they have better pulmonary status, so they usually need shorter duration or less intensive ventilatory therapy. But there could also be some maturation of the cerebrovascular architecture. So looking at the magnesium sulfate as a neuroprotectant, so magnesium has been used as a tocolytic for a long period of time, and also for seizure prophylaxis in women with severe preeclampsia. But since 1995, it has also been used as neonatal neuroprotectant, because it has magnesium has anti-excitatory and antioxidative stress or antioxidant stress, and also reduces inflammation. It also stabilizes cell membrane and improves cardiovascular stability. So there have been 5 RCTs, 3 of them looking at the fetal neuroprotection, and collectively they showed there is a lower risk of cerebral palsy in the babies whose mothers received magnesium sulfate. And the number needed to treat is given here. It's seen with both babies born before 30 weeks as well as babies born between 32 and 34. all babies below 34 weeks and below 30 weeks. And there was no increase in perinatal and infant mortality. However, magnesium sulfate is a category D drug, so there is a potential for bone malformation. So continuous use beyond 5 to 7 days is discouraged. It's also interesting to know that when people went back and looked at the outcome of the studies where magnesium was given for tocolysis or for seizure prophylaxis, they did not see this neuroprotective benefit. In fact, there was a little bit of an increased neonatal or post-neonatal mortality. So again, it's a little difficult to know as to whether the magnesium had a role in that or whether it is just a manifestation of the population for which it was used. So maybe because of that, the American College of Obstetricians and Gynecologists does not have any specific recommendation for magnesium sulfate use, but the Australian as well as the United Kingdom and Canadian societies have specific recommendations. So in our place, women get both antenatal corticosteroids and also the magnesium sulfate in cases where preterm birth appears to be imminent. The other measure that has shown to have a significant impact on neurodevelopment is the delayed or timed cord clamping or cord milking. So delaying the cord clamping to about 30 to 120 seconds or cord milking reduces the mortality. So there is a 60% reduction in mortality. There's a lower need for transfusion, about 25% reduction, and there's a lower incidence of intraventricular hemorrhage. And this effect is seen without any associated increase in morbidity. So we do worry about conditions such as, for example, hyperbilirubinemia. So that has not been the case. And a recent study showed that even in full-term infants who had delayed cord clamping, their fine motor and the social domain scores at 4 years was higher. So is it because they had better hemodynamic stability, or is it because delaying the cord blood is a good source of stem cells also? So there is some feeling that by delaying the cord clamp, these babies are getting more stem cells also. So our unit does practice timed cord clamping for both term as well as preterm infants. Then after the baby is born, there are certain strategies that are taken mostly to prevent the occurrence of intraventricular hemorrhage. So the evidence-based strategy in that is indocin prophylaxis, and then there are some empiric strategies that have been used, such as midline head positioning, avoidance of hypercarbia and hypocarbia, and hemodynamic instability, and synchronized ventilation. There are also other measures that have been tested and proven not beneficial in reducing the incidence of IVH, such as the mode of delivery, C-section versus normal delivery, CPAP versus mechanical ventilation, and pharmacological interventions such as phenobarbital, prenatal vitamin K, maternal magnesium, vitamin E, and so on and so forth. So looking at the indocin, so we have used indocin for PDA closure for a long period of time, but it is shown that at lower doses, indocin actually reduces the incidence of intraventricular hemorrhage. So small studies were very strong. There's a strong evidence in many of the small studies. So this randomized control trial compared low-dose indocin versus placebo on days 1 and 3 in about 430 babies. And they did find that the incidence of both intraventricular hemorrhage, any intraventricular hemorrhage, as well as a severe intraventricular hemorrhage was lower in the group that received indocin. And there was also a lower incidence of PDA, especially the one that needed surgical ligation. And there have been few other studies. So when you look at the meta-analysis, this protective effect was seen with especially for the severe IVH. However, when they looked at these babies both later at 18 to 24 months and then even at 5 years, there were no long-term beneficial effect on neurodevelopment. So at the end of all these studies, there are essentially two groups of practice, or two ways of practicing. There are units like ours where we feel that avoiding even a single case of severe IVH is worth giving this indocin, and we do use indocin in our population. And then there are others that feel that since there are no long-term benefit, giving endocrine which may have some side effect, for example, on the renal function. So they do not use it. So looking at the empiric strategies, so we have in our NICU did what is known as a neuroprotection bundle, something essentially looking at the activities that are targeted at protecting the developing brain. So this was done through the Vermont-Oxford initiative, for which we are one of the units that are participating in. So a long series of measures were developed, as you can see here, looking at the target population, measuring starting at the delivery room, and then going on the way, involving everyone, providers, respiratory therapists, parents, and then the nursing staff. But if you can group them all together, it will probably can be summarized as midline head positioning, mostly to prevent any blockage to the venous flow from the brain, continuous cerebral near-infrared spectroscopy monitoring, avoidance of excessive stimulation, that includes even avoidance of noise, avoidance of hypothermia, and then hypo and hypercarbia, because that can have an impact on cerebral blood flow, and then again avoidance of hemodynamic instability. So the reason we chose to do this is the incidence of severe IVH in our unit was suddenly higher than what we typically were seeing. So in 2013, it was as much as 12%, whereas the average for the units or the centers in the Vermont-Oxford network was about 8%. So our goal is to reduce that to 5.7%. So we developed this neuro bundle, and then we did start some of them decreasing the noise level. So we don't use, our phones are kept for vibration or silent mode, so we don't have the noise, because noise is a big stimulant. And then we introduced the bundle in 2014, but as you can see, already the incidence had come down even before the bundle was introduced. And further refinements were done by delaying the cord clamping, and then now actually sending the labs. So one of the big lab draws that we have to do will be around the time of delivery, because the babies need a lot of blood work. And we are now started doing many of those using the cord blood. So that will limit the amount of blood drawn from the baby, so that achieves better hemodynamic stability. So the incidence has definitely come down. Difficult to say whether it is because of the neuro bundle, but since it is going down, it is much more encouraging. And some of it could be just because the number of babies who actually end up with severe IVH is small enough that just having maybe 1 or 2 extra babies can skew the data. But so far it looks like it is working well. The other neuroprotectant that has been used for premature babies is caffeine, something that we have used for apnea of prematurity for a long period, more than 40 years. And caffeine does inhibit adenosine receptor, so there is a theoretical possibility that it can cause brain injury. So that was the purpose, or that was the rationale for doing this study, to see whether caffeine given for apnea of prematurity, whether it causes brain injury or not. So this was a large study, about 2,000 babies, and they received caffeine or placebo starting at less than 3 days after birth and all the way to 35 weeks. So babies who got caffeine obviously had less apnea, so that was good, that at least we were treating something that we thought we were treating. But it was also noted that these babies had lower bronchopulmonary dysplasia at 36 weeks corrected gestational age. So about 37% decrease incidence of BPD, and they also needed less respiratory support. And when they looked at the neurodevelopment at 18 to 21 months, the babies who received caffeine had better neurodevelopment. So their survival without neurodevelopment incidence was about 23% lower compared with the placebo. And the number needed to treat is about 16. So in other words, 16, if you give caffeine to 16 babies, you will achieve better neurodevelopment in 1. And there was also lower rates of cerebral palsy, severe ROP, and cognitive delay. But when they looked at these same babies at 8 years, the beneficial effects were no longer seen. And some of the reasons for this discrepancy is When we look at the neurodevelopmental assessment at 18 to 21 months, the standard testing that we do is called Bailey Scale of Infant Development. And Bailey Scale of Infant Development is heavily weighted on the motor development. And many of our babies, especially the small ones, because of their underlying respiratory disorders and malnutrition, they have much lower tone, or they will have usually motor deficits. So their scores at 18 to 24 months, probably we are over diagnosing or overestimating the neurodevelopmental problems. And the caffeine's advantage in improving the respiratory support may explain why these babies had better neurodevelopmental score. In fact, when they went back and looked at the 8-year data, the ones who showed the most improvement between 18 months and 8 years were those who had the lowest neurodevelopmental score at 18 months. In other words, they gained the most between 18 months and 8 years. So this could be one of the problems in some of the data that we see. However, some of the reasons why we do the 18 to 22 or 24 months assessment is the way the NIH funds. It's a 5-year cycle that typically we do. So it takes about 2.5 years to recruit the patient population, and then you just have about 2.5 years to do the neurodevelopmental assessment. And it also provides a safety net, so to speak, because you don't want to wait all the way until about 8 years to realize that we were actually causing more harm than good with our intervention. So the newer kids, the new kid in the block is erythropoietin. Erythropoietin is something that is produced in the fetal liver, and then the kidney takes over around term and continues beyond. And it regulates mostly hematopoiesis, so has been used for correcting or preventing anemia. And we have used in the NICUs for over 30 years. But in 93, there were studies that showed that there are EPO receptors expressed in the mouse neurons. And then they went on to show that it is also expressed in the human brain, both developing as well as the adult brain. And neurons, astrocytes, oligodendrocytes, and microglia, all of them have these EPO receptors. So then people started wondering as to why there are these EPO receptors. And when you look at conditions with chronic hypoxia, for example, infants of diabetic mother or IOGR infants, there is an upregulation of EPO, even antenatally, but you don't see that after acute hypoxia. So looking further into the non-hematopoietic effects of EPO, EPO does have neuroprotective effects. It reduces the apoptosis, oligodendrocyte injury, inflammation, and oxidative injury. And then it also is a growth factor. So it improves BDNF, brain-derived neurotrophic factor. It improves neurogenesis, oligodendrogenesis, glial cell proliferation, and angiogenesis. So there have been then, looking at the risks in adults, the high-dose EPO especially is associated with hypertension, clotting, and polycythemia. And there's also a risk of tumor growth in people with cancer. And in some cases, there have been death due to stroke. But if you look at the population that is likely to get EPO in adults, many of them will have chronic renal failure. So as such, they are at a higher risk of having hypertension and associated complications. So some of this could be related to that. And none of these effects have been reported in preterm infants. But there is a potential for developing retinopathy of prematurity because it is an angiogenesis factor. And also there is an effect of probably seeing an increased incidence of hemangioma in preterm infants. But there have been a recent study from Switzerland which did not show any similar effect at high-dose EPO. And currently about 500 to 3,000 units per kilo is considered safe in both term and preterm infants. So there have been trials in both full-term infants as well as in preterm infants. In full-term infants, there have been trials looking at hypoxic ischemic injury, some of which we talked about, arterial stroke, and then post-cardiac surgery. And in preterm infants, there have been trials of both low-dose and high-dose EPO. So the full-term, so this is a short list of full-term infants with hypoxic ischemic injury where the EPO has been tried. Many of the trials were phase 1 and phase 2 trials. looking at the safety and efficacy and pharmacokinetics. But there have also been studies looking like a phase 3 trial, which is yet to start. There's also a NETO trial that is yet to start. The other population in the term infants have been looked at arterial stroke and also cardiac surgery in neonates with cyanotic heart disease. Again, these have been mostly phase 1 and phase 2 trials. In preterm infants, there was a trial comparing the low-dose EPO that was published about a year and a half ago in infants less than a kilogram and less than 28 weeks. A third of the babies got the EPO at 400 units per kilo thrice weekly. This is the dose we used for promoting erythropoiesis in the NICU. And darbepoetin is a synthetic derivative of EPO. The advantage is it can be given once a week instead of giving it 3 times. And then there was a third group, which was the placebo. So they started the EPO within the first 48 hours and went until 35 weeks. And as expected, babies who received either EPO or DARBE had 50% fewer transfusion. And they also had better neurodevelopment at 18 to 22 months and better cognitive score as well as lower risk. And this was seen whether it was with EPO or with darbepoetin. And the unpublished data now suggests that the beneficial effect persists at least until 3.5 to 4 years. So there is better IQ and executive function in the babies that received the EPO. And the beneficial effects seem to correlate with the serum EPO levels, meaning the higher the serum EPO levels, better was the outcome. So there has been a second trial which looked at then the high-dose EPO, and this was the Swiss EPO study, where they randomized infants between 26 and 31 weeks to either EPO or to placebo. And they used a high-dose EPO, 3,000 units per kilo, 3 doses in the first 48 hours. And then they looked at their MRI at term age, so there was less white matter and gray matter injury on MRI. Their 18 to 24 month data are not very promising. There were not much of an effect. And then now they are looking at the 5-year neurodevelopmental data. So this study just got completed in 2012. So the data should be coming sometime in 2018 or 2019. And one of the criticism or one of the concern as to why they could not see these beneficial effects at 18 to 24 months is they gave these high doses all within the first 42 hours, whereas the earlier study had gone all the way, even though the dose was lower, they had gone all the way to 35 weeks. And then if you remember the pathogenesis of brain injury in preterm infants, it is really a long drawn process. Injury takes place not only during the initial neonatal period, but continues during the reparative process. So that is what is now addressed in the PEANUT trial, which is a randomized placebo-controlled trial. It's a phase 3 trial of erythropoietin for neuroprotection. And the hypothesis here is that EPO treatment of babies between 24 and 27 weeks will decrease the combined outcome of death or severe neurodevelopmental deficits from 40 to 30%, and then death, severe, and moderate and neurodevelopment impairment from 60 to 40% at 22 to 26 months. And this is the overall plan as how the study is done. Babies get enrolled soon after birth, within 24 hours. And those who are assigned to the EPO will get this 1,000 units per kilo. So it is not as high as the Swiss study, but higher than the low-dose EPO study. So they get 6 doses every other day for the first 2 weeks. And then they get continued on the 400 units, the one that we have used for the erythropoiesis, until they are 33 weeks. And they will have an MRI at 36 weeks, which we happen to be one of the MRI sites. And then they will be followed at 22 to 26 months, where we will have a standardized neurological exam, Bailey scales, screening for autism, and then also, because we don't know much about the renal development in this population, so there is also a companion study called REPAD study that is tagged along to this, and they will be looking at the renal development in the same population, going all the way until 24 months. So the primary site is in Seattle. University of Washington. Sunny Jewel is the overall PI. And there are 19 sites and 30 hospitals, including us and North Memorial and Minneapolis Children as well as St. Paul Children's Hospital. And as of now, about 80% enrollment is complete. So the study started December of 2013. And we here at Masonic Children's as well as the North Memorial together have enrolled more than 40 babies. Altogether, about 130 babies have been enrolled from the Twin Cities thus far. So last, I just want to touch upon the potential role of stem cells for repair as well as prevention of neonatal brain injury. So we all know there are many sources for getting the neural stem cells. So anywhere from embryonic stem cells, induced pluripotent stem cells, as well as somatic stem cells, mesenchymal stem cells, adipose tissue, umbilical cord. All these sites have stem cells that can be induced to create neural stem cells, which will then go on to produce neurons, astrocytes, and oligodendrocytes. Now, among this source of stem cells, the embryonic stem cells have ethical consideration, but also there is a potential for tumorigenicity. It's also true for induced pluripotent stem cells. But the somatic stem cells, especially the mesenchymal stem cells, seem to be having better ability to repair. And out of this, the cord blood stem cells seem to be really promising. Cord blood is a very rich source of stem cells, and I already alluded that one of the benefits of the delayed cord clamping is said to be because we are giving more stem cells to these babies. And the cord blood can be, then you can get mesenchymal stem cells, endothelial progenitors, and others. And then you don't really need the blood. You can actually get the mesenchymal stem cells from the Wharton's jelly also. And they have lower immunogenicity and easy to differentiate into mature cells, including the neurons. And they have been used for a host of malignant and non-malignant conditions, including at our site. So the animal data are quite promising. So there have been models of hypoxic ischemic injury as well as arterial stroke. And people have used neural stem cells, mesenchymal stem cell, cortical graft, as well as umbilical cord cells, both locally as well as systemically, and have given it both immediately after the occurrence of injury or delayed for repair. And beneficial effects are seen with all these cells, essentially the embryonal stem cell, neural stem cell, as well as the human cord blood stem cells. And the benefits are not because of engraftment. Even when you inject them locally, directly into the parenchyma, less than 1% of the cells actually survive. So if you go back and look at these cells, most of the cells will die and go away. They do not get formed. They do not get incorporated into the existing networks. So the way the stem cell works is actually through paracrine or trophic factor. Somehow it makes the local stem cells or the local reparative mechanism start working. And stem cells do have anti-inflammatory and anti-excitotoxicity properties, and they do promote synaptogenesis. And animal data suggests that the results are better with immediate post-injury administration. There have also been some data from the humans, mostly in cases of severe brain injury, where human neural stem cells have been directly injected in phase 1 trials in conditions with severe brain injury, such as neuronal ceroid lipofuscinosis and Merzbacher disease. And there have been trials done with human cord blood stem cells for Krabbe disease, and then also for those with established cerebral palsy. A study in China and Mexico have looked at the safety and feasibility. And then there is an ongoing randomized controlled trial at College of Georgia and also at Duke. So one of the studies that was done in Duke of interest to us is the autologous cord blood stem cell for hypoxic ischemic injury. And this was done in infants more than 35 weeks. And they received the autologous cord blood stem cells. So in cases where it appeared that the baby was, or the fetus was in distress, either because of meconium passage or fetal heart rate, they approached the family and collected the cord blood, either after the baby was delivered and the placenta was still inside the uterus, or after the placenta was expelled. And they were able to use the cord blood in about 2/3 of such collected blood. And they infused them soon after birth, and the first initial part they gave 3 more doses, but then the FDA was involved, and after that they only had 2 doses given. They gave a hydrocortisone pre-treatment, and there were no safety concerns. And when they looked at the 1-year survival with babies with Bailey scale of infant development greater than 85, comparing the historical or the concurrent population that just received hypothermia, there were comparable data, although it looks like there was some benefit with the in the stem cell group, but this was not a randomized trial, so we cannot draw too much of a conclusion. So there are current stem cell trials. In full-term infants, there is an umbilical cord milking for hypoxic ischemic injury, which is being conducted in India in collaboration with investigators in Jefferson University in Tennessee. And then there are 2 other studies looking at the autologous cord blood, one in China and one in New York Medical College, that have yet to recruit. And there is also a trial that is active now looking at mesenchymal stem cell, umbilical cord-derived mesenchymal stem cell called Pneumostem as a phase 1 trial for preterm infants with IVH that is ongoing in South Korea. So in summary, progress in clinical care has improved neonatal survival rate without affecting brain injury rates, and neuroprotective strategies are thus necessary to ensure optimal neurodevelopment. And to be effective, such strategies have to be tailored to the population at risk, and also will depend upon the type and timing of the brain injury. And a multimodal approach will potentially achieve best results. And I want to conclude by showing this baby. This is the first baby enrolled in the peanut trial in University of Washington. Thank you. Yes, Fu. I suppose use a mic. No, I think they want to record it.
You can repeat that question.
I can repeat the question, yes.
So what does it take 60 years almost from the initial observation of hypothermia to the current treatment?
Yeah. So the question here is, it takes about 6 years for 16 years.
So was it from 1958? When was the initial?
Yeah, so there were studies. So the question is, why it took 60 years for hypothermia to become standard of care? So it was interesting that in 1958, when the study showed that babies self-cooled themselves, there were actually trials. So it was quite common to actually keep the babies cold by dunking them in a bucket of ice. So they did those studies, but then it was shown that keeping the babies warm is what we have to do. So the isolate was invented around in the 1950s. And we went from keeping the babies cold, we went from there to go to keep the babies warm. Because if you look at the overall, there is an association, there's a mortality with excessive cooling, especially during the transport. So it just shows that we just thought that warming is better than cooling, and it's mostly because of the isolates. There is a huge gap. And then the other point I wanted to make is, because you're right, it takes, I think, about 10 years for from going from small studies for a neuroprotective strategies to be applied system-wide, because it takes that long, because you want to wait at least until 5 years to know whether the intervention is working or not. So there is actually a parallel research or a parallel progress that is being made looking at biomarkers. Do we have any biomarkers that is going to show that the benefit or the no benefit can be seen? So an example I can give you is one that is done by Katie Pfister in our group. So she is looking at, in the hypoxic ischemic injury babies, she's doing the event-related potential, the ERP recording, and to see whether the changes that are seen in the ERP are reflective or predictive of what we see down the road. So there is also the other one they are looking at is all the serum biomarkers. There are biomarkers in the MRI people are looking at. So there is a parallel investigation that is going on. Okay. Okay. That's it.
You have been disconnected.